The following program is brought to you by Wightman TV. All content in the Stay Strong, Live Long Falls Prevention Education series has been created for informational purposes only. The content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have heard on this television production.
Welcome to our Stay Strong, Live Long Falls Prevention series, brought to you by the VON, the Upper Grand Family Health Team, and our community partners. Falling is the leading cause of injury-related death among seniors and the #1 contributor to loss of independent living. In fact, 1 in 3 seniors 65 years and older will fall each year, and falling once doubles one's chance to fall again. So we're hoping through this Wightman Telecom production that we can change these statistics in Wellington County, empowering our community with the knowledge and tools they need to prevent future falls. Today's session includes the topic of sensory deficits, and our first speaker is Mary Young, and she is a hearing care counselor with the Canadian Hearing Society. So thank you very much, Mary, for coming.
Thank you, Julie. Hello everyone, good morning to those that are here, good morning to those that will be watching all the presentations on the Wightman Telecom TV series. As Julie indicated, I work for the Canadian Hearing Society, which was founded in 1940, and we're a nonprofit organization. We are a leading provider of services, products, information that remove barriers to communication, advanced hearing health, and promote equity for people who are deaf, oral deaf, deafened, and hard of hearing. The Hearing Care Counseling Program is just one of the many programs offered through the Canadian Hearing Society to people in Ontario. Other services that assist clients are employment, general support services, Ontario interpreting services, mental health counseling, and communication devices. For more details, you can go to our website, which is www.chs.ca, and that information again will be listed on the bottom of this section of the program so that you can have a pen and paper handy to write it down. The Hearing Care Counseling Program that I coordinate in Wellington and Dufferin counties is offered from Windsor to Thunder Bay, and it's geared for the older adult, 55 or older, who may be having some sort of issue with their hearing, to help them with their family, caregivers, friends, on the telephone, and at public gatherings. This program is also offered to older adults in the community who may have another disability as well as a hearing loss and require home visits. As a hearing care counselor for Wellington and Dufferin, I do a great deal of my work as an outreach counselor. So I come to your home, I sit at your kitchen table and help you deal with the issues you're having around your hearing. I go into retirement homes, long-term care facilities, and even to local senior centers. I don't sell hearing aids, but I'm first and foremost a counselor helping you, the consumer, your spouse, your family, your friends, deal with changes in your hearing. Hearing does change over our lifetime. For most of us, by the time we hit the age of 51, we are starting to experience bouts of, what was that you said? Especially if you're in an environment where there's a lot of background noise. You'll start to lean forward and say, what was that Julie said? Because it's not quite making sense. By the time we hit 65, 1 of 2 people will have a hearing loss, and that's just the normal aging process. Most have never been to a hearing screening that I can offer in the community. Many have never ever had their hearing tested over their lifetime. The Canadian Hearing Society, as well as audiologists and hearing instrument specialists in your community, offer hearing tests. I offer free hearing screenings, which is a baseline in people's homes, at the senior center, and I also offer follow-up workshops that can kind of give you what is a hearing test versus the screening that I was just at. What are hearing aids all about? How do I get used to them? What's the cost? How long will it take me to get used to my hearing aids? What are good communication strategies? Because hearing aids are only one part of dealing with the change in your hearing. What devices are out there that could help me? What are the common signs of hearing loss? Well, the first and foremost is repetition. What was that you said? Could you repeat that? Misunderstanding what was said. Having great difficulty, as I said before, in noisy environments. Many people now go to our local Tim Hortons for their morning coffee, and they get together in a group, and when the Tim Hortons is at their peak busy time, sometimes people sitting there lose the flow of conversation because they just have so much background noise around them. You turn the television volume up, the radio in the car is up really loud, thinking people are mumbling. What I just said is thinking people are mumbling. At church, family gatherings, social gatherings, people often with a hearing loss that are having trouble following the flow of conversation tend to tune out. They stare off, they're thinking, okay, after church I'll go home and I'll do this and I have to remember to call this person back, and they're not following the conversation, the sermon, missing conversations at a party. Withdrawing. Many people withdraw from those social events. Honey, you go, I'm not going to go. You may find you answer inappropriately. You hear something and you answer back and people kind of look at you or they laugh. Your doctor asks you specific questions and then kind of looks at you because your responses are not appropriate to the question. Over time you may start to bluff. You nod your head, you smile, or you go, and you have no idea what the person may have said to you. The constant repetition of your spouse, your family members, friends, repeating and repeating what has been said to you can get really stressful for those individuals in your life. Now for a short anatomy lesson. This is a model of an ear. And our ear is made up of three parts: our outer ear, our middle ear, and our inner ear. Our outer ear is made of our earlobe, down the ear canal to the eardrum. Earlobe is great for hanging your glasses on, earrings, even a hearing aid. The middle ear is made up of three small bones, and this is often where people have ear infections, children, even adults, middle ear infections. The third part of our ear is made up of two components. The first one is called the cochlea. It's a labyrinth, hollow bone filled with liquid, and in that liquid are microscopic hair cells. And the air wave that's coming through the chain of your hearing, when it gets to the cochlea, nerve endings, very specific ones, are triggered by sound waves, sending the auditory signal to the brain, to your auditory cortex, and you hear my voice, the birds, the train, traffic, whatever happens to be in your environment. The second part of our middle ear, our inner ear rather, is called the semicircular canals or the labyrinth. And this is where our balance mechanism is located. And this in the older adult is often an issue with balance. And again, we're talking about preventing falls. So people often are told, sit on the side of your bed when you first get up, because you've been on your back or your side all night, and then you stand up and get halfway across the bedroom, heading for the bathroom or your first cup of coffee, and you go, whoa, and you're dizzy. Again, dizziness, off balance, chance of a fall. What's happening is the plane has been either here or here, and now you stood up and you started, and this takes time to realign from one plane to the other. So that's why it's advisable as you get older to sit on the bed, kind of give yourself no more than 30 seconds, a minute or two, to get this back so that things that are triggering your balance mechanism are back in the upright plane. I was asked to be part of this falls prevention series because there is some research that indicates a possible change in your hearing affecting your balance. A new study led by Johns Hopkins researchers Dr. Frank Lin and Dr. Luigi Ferrucci suggests that hearing loss may also be a risk for falls. The study that they did of over 2,000 participants ages 40 to 69 had their hearing tested and then filled out a questionnaire about whether they had fallen over the past year. What was found, and I quote, people with a 25 decibel hearing loss, which is considered a mild hearing loss, were nearly 3 times more likely to have had a fall over that past year. For every additional 10 decibels of hearing loss, the increase of chances of falling was 1.4-fold. This finding still held true when researchers accounted for other factors linked with falling, which included age, sex, race, cardiovascular disease, and vestibular function. Dr. Lin, who's an otologist and epidemiologist, says that among the possible explanations for the link is that people who can't hear well may not have a good awareness of the overall environment, making tripping and falling more likely. With hearing, we have the ability to hear 360 degrees all around us. For example, we hear sounds that may be behind us. So an example would be we hear a shopping cart in the grocery store coming up behind us. Our body instinctively, when we hear it, makes that millisecond, oh, there's a shopping cart, I might need to get out of the way. Because our brains can register sounds a fraction of a second earlier in one ear than the other, that helps us pinpoint exactly where is the cart. Is it here or is it here? So for example, if I heard that sound slightly sooner in my left ear, I would instinctively move to the right to avoid being hit. And yet I don't see the cart nor the person, but I've heard them. Another reason for hearing loss, according to Dr. Lin, is the cognitive load, in which the brain is overwhelmed with demands on its limited resources. Dr. Lin goes on to state, gait and balance are things that most people take for granted, but they are actually very cognitively demanding. If hearing loss imposes a cognitive load, there are fewer cognitive resources to help with maintain balance and gait. As we take time to hear things correctly, it takes extra energy. Many people indicate how tiring it can be to listen. We're trying to follow the flow of the conversation. We try to fill in the missing words. We try to fill in those gaps. And our brain is forced to work much harder to fill in those gaps. For example, if I said to you, I really like the green chair, Julie might say, what's Mary talking about? Because the word green and chair in our English language do not go together very often or at all. But what if I had actually said green chair? I really like the green chair. Two very similar consonants, sh versus ch, but make the world a difference in understanding what the sentence is about. And of course, if you mishear, you're back here trying to figure out what I'm sharing that's green. Meanwhile, I'm talking and then I'm looking at you because you're not responding to me. Now envision doing this every day, all day, and how tired the brain will become. There's also medical situations that cause bouts of vertigo or dizziness that you might not be aware of. The first type is known as benign paroxysmal positional vertigo, and this is the most common disorder in the older adult. It's felt like you're spinning or that you see your environment spinning, and it's triggered by a change in the position of your head or your body. For me, it's a sensation that's immediately triggered if I'm sitting on a train and I happen to get the seat that goes backwards, and I look out the window and I'm instantly very, very dizzy. For others, it may be when you bend over, you turn over in bed, you stand up getting out of bed to get ready for the morning. Labyrinthitis is an infection or inflammation of that inner ear part, causes vertigo, that dizziness, severe imbalance, hearing loss, and the imbalance, of course, can affect your walking, and again, that has a risk for falls. Meniere's disease causes similar symptoms and is thought to be a result in the increased liquid in the inner ear. Meniere's disease usually affects one ear, but up to a third of the patients indicate that it's in both ears. It can cause bouts of vertigo, that's spinning, where you feel like you're spinning or you see the world whirling in front of you. Tinnitus, which is that ringing in your ears, a feeling of fullness in your ears, and a hearing loss that kind of goes up and down. Bouts can last from a few minutes to several months. New research has also shown a link between undiagnosed hearing loss and early onset dementia. Dr. Lin, that I spoke of earlier, is now doing research in this area. If you think about it, it makes sense. If you have a hearing loss, how can you remember what you never even heard? Or how can you process correctly what you misheard? Like the time my dad went to a medical appointment that he thought was at 1:50 p.m. So he arrives for his medical appointment, goes up to the desk, and the staff at the desk say, "Mr. Moore, you were supposed to be here at 10 o'clock this morning. We'll have to reschedule you to come tomorrow." When I got home from work that night and called him to say, "How did your doctor's appointment go?" He informed me that he had to go back tomorrow, and I said, "Well, why is that?" And he said, "Well, they called the day before and asked me if I would come at 10 to 2, and when I got there, I was told that I was to have been there at 10. Now, my dad was a longtime farmer. He had a hearing loss. He wouldn't get hearing aids, and he wouldn't acknowledge that he had a hearing loss. So I suspect what was said was, "Could you come at 10 instead of 2? And he heard, "Come at 10 to 2. So if I hadn't known that my dad had that hearing loss, I might have stepped back and thought, "Oh dear, do we have the start of memory loss because my dad has forgotten an appointment and forgotten the time?" But because I knew of his hearing loss, I suspected that it was the hearing loss. So we put steps in place. They called me whenever there was a change in an appointment because my dad would never repeat. "So you want me to come at 10 to 2? Where if he had said that, he probably would have been told, "No, Mr. Moore, come at 10 a.m., which then he may have heard on his phone. How can one deal with a suspected change in your hearing? Well, you might connect with the Canadian Hearing Society, connect with the hearing care counseling program that I offer in your community, and give me a call. Part of the counseling is to assist people to deal positively with a change in their hearing and help them understand hearing loss and its relationship to staying safe and independent in your home. For example, suggesting that you might change the number of rings on your answering machine if you've told me that you often don't hear your phone ringing unless you're right close to it, and when you do, you often get up and try to rush to get it before the phone picks up after the third ring. So we might want to change it to 5 or 6 or even 10, which gives you lots of time to get to the phone before you know the answering machine is going to cut the conversation off. A discussion about hearing aids might be benefit and lower the risk of your falls because you hear sounds sooner, you hear them more clearly, and you hear where they're coming from. Over the past decade, technology in hearing aids has really advanced. They now even have Bluetooth technology in them, where you can have devices for the TV, you can link to a cell phone, or I could have even a little microphone like I'm wearing today, and you could sit in the far back corner of the hall, and it would sound like I am talking to you right in front of you, because what my speech is all about is coming through your hearing aids, and this is all done wirelessly. But hearing aids are aids. They have boundaries, and they don't need to be hidden. But they do have parameters on how much they can help a person hear. Part of my counseling is to help the consumer, their spouse, family, friends, understand the realism of their hearing loss and the realistic expectations of hearing aids. But hearing aids are only one part of dealing with your hearing loss. This loss is really a breakdown in communication. So here are some simple steps to put in place. You need to speak face to face. Years ago, when you and your spouse first were married, you were able to talk to each other easily in the same room, different parts of that level of your home, even from upstairs. But you can't do that any longer. So you need to be face to face. You need to be able to see their eyes to communicate better. Get the person's attention. Make sure that they acknowledge that you are speaking to them versus they're thinking of something else. They hear you, but they're not understanding what you're saying because they're not focusing on you. Speak a little louder and a little slower. And I don't mean talking like this because that's not natural and it puts people's defenses up. So you speak a little louder and a little slower. Honey, yes, I'm going to the kitchen. Would you like a cup of coffee? Versus, honey, I'm going to the kitchen and would you like a cup of coffee? What was that you said? I'm going to the kitchen, and you still don't get it. And after the third repetition, kind of the fangs come out. The voice comes up, the stress is in the voice, and then that back and forth stress just builds. Actually tell people what you heard, especially if you're in a noisy environment and you've only caught part of it. So instead of nodding your head and smiling and go, uh-huh, say, what was that about the dog? And this comes from a real example that a client gave me years ago. He was at a function in the community. He'd stopped to speak to his good friend Joe, who he had known for years, and he heard something about the dog, but because he was into bluffing, he said, oh, that's nice to hear, Joe. Take care, and started to walk away. But the change in Joe's face made him stop and think, oh, what is that? So he knew enough to turn back to Joe and say, Joe, it's noisy here. I heard something about the dog, but I didn't get it all. And Joe said, the dog got hit on the road last night and we had to have her put down. And this gentleman told me that he, at that point, realized he needed to do something about his hearing because the bluffing had the potential to lose and ruin a long-time friendship because his response to what Joe had said was totally inappropriate. Use humor. We're human. We forget. We walk away and start to talk. And then the person listening to us can't hear, and then you get a little upset with them. Use humor. It always diffuses the stressful situations. And lastly, realize that communication is that invisible communication back and forth. We listen, we speak, we hear all these wonderful sounds in our community. And this just happens many, many times during the day. As I said at the beginning, we have communication devices, and the Canadian Hearing Society has an extensive department where we have a variety of amplified phones. We even have specialized smoke and CO detectors that can be linked to a strobe light. I have many clients with a high-level hearing loss that when they take their hearing aids out at night, they don't hear the regular smoke detector. So again, that's a risk factor for staying safe in your home. So you can put in new smoke and carbon monoxide detectors that will trigger a strobe light. We even have one very specialized amplified phone. You can wear either a wrist fob or a medallion that has a button on it. This phone can have 6 pre-programmed numbers, and if you need help, i.e. you've had a fall, you could press the button and the phone will keep dialing through those numbers until it gets a person. And then when the person picks up, they can speak through the phone and say, Mom, it's Mary. You called me. What's wrong? Do I need to come over? What's happened? There's an assistive listening device that I brought today. This is called a Pocket Talker Pro because hearing aids aren't always the best for everyone. This is a headset you put on. It has a microphone. You turn up the volume. Very easy to use. This, I know Julie uses it in her work with talking with people because then you don't have to keep repeating or talking too loudly. Works really well for people in long-term care where getting hearing aids in, they can't do it anymore independently. They often are lost. This is pretty hard to lose and misplace, but very simple to use. As you can see, hearing loss can have an impact on the quality of your life. But by dealing with this communication breakdown, you'll be able to be more involved with your family, social activities, decrease the possible stress with your spouse, and reduce the risk of falls. If you suspect yourself, your spouse, your next door neighbor or somebody you know has a hearing loss, let them know about the programs that are offered through the Canadian Hearing Society. Our programs are at no cost to the consumer, and we're just a phone call away or even an email. So thank you very much for including me in this presentation, and I'll open the floor up to any questions. And again, the information will be on the end of my presentation, my phone number and contact. Thank you again.
I have a question about the pocket talker. Do you wear that by itself or in conjunction with a hearing aid?
Good question. So the question was, with the pocket talker, would you wear it with your hearing aids or alone? Actually, you would wear it alone. If you put this over your hearing aids, anyone who wears hearing aids would know if you given a hug or you put your hand up over your hearing aids, you get what we call feedback, that whining, whistling, because it's a closed chamber. So you would take your hearing aids out to wear this. I have clients who have hearing aids, and this as well, because they find, the one lady lived in a retirement home, and as I tell people who live in retirement homes, long-term care facilities, it's like going out to a public restaurant when you go for a meal. So she found that with the staff and the carts, her hearing aids picked up all that noise. So she took this to her noon supper meal and took her hearing aids out so that she could lay it close to the person across, because they like to talk, but people's voices got overwhelmed by the background noise. So they could pick it up and hold it, and it made the world a difference. So you would wear this independently.
Thank you.
Okay, any other questions?
Yes, I have a question.
Oh, Cassie?
Are there any coping strategies for tinnitus?
Yes, there are. The question was, are there coping strategies for tinnitus? That was that reference I made with Meniere's, that humming, buzzing. Although tinnitus can be a humming, a buzzing, can be cricket sounds, snippets of music, whirring, water running, vacuum sounds, so it has a real spectrum of what you hear. It's a irritation anywhere from your outer ear to your brain, and your auditory cortex is picking that up. Many of the audiologists in the business, and even I have a handout that has a little synopsis of what all the services the audiologist and hearing instrument specialists offer. I will list that they have training in tinnitus retraining therapy. So what I tell my clients is it's it's a central nervous system issue, so there are triggers. Some people have a hearing loss and tinnitus, other people have tinnitus but don't have hearing loss. So this tinnitus can be triggered for some. So let's say I went to Julie's for a meeting, and Julie's a tea drinker, and she's made coffee that's really strong. And then she gave us lovely chocolate cake, and I had 2 pieces. So I tell people, journal over several weeks or days what your tinnitus is doing. So you may say, okay, I was at Julie's the night before, I had a cup of coffee that was really strong, and I had 2 pieces of cake. The caffeine in the cocoa, the caffeine in the coffee, my tinnitus is really buzzing today. So was it a relationship to caffeine? Some people have artificial sweeteners. Some people, the weather triggers it. They will tell me that they know when there's a high or low coming through, much like migraine sufferers, because their tinnitus is much more pronounced. Some people with hearing loss who go and get hearing aids find that their tinnitus is kind of pushed to the back of the bus because they're hearing more sounds loudly, so that tinnitus is not as noticeable. I asked my dad when I started in this job, because I was learning about tinnitus, did he have it? And he said, oh yes. And I said, well, how long have you had it? Because he'd never mentioned it. And he said, oh, for years, but I'm so used to it, I don't even notice it. He said, oh yeah, it's there. But otherwise, he had just had it for so long that he was habituated to the sound. Other people struggle more. They used to say, put yourself in a quiet environment and that'll help. They've really gone 360, gone the other way. Have noise in your environment. It keeps the auditory cortex working. Kind of like Dr. Lynn's research. You know, you need to keep your brain as active as possible, the auditory cortex working. So have the TV on, have the radio on. We even sell what we call sound conditioners, which can help people if they're not able to go to sleep or wake up in the night and can't go back to sleep. Some of them are just white noise. Others can be crickets. Wouldn't help me. It would keep me awake, crickets. But it could be running water. It could be rainfall. You might find you put the radio on and you listen to the radio and you're listening to it and not focusing on your tinnitus. So there is help out there. Yes?
My mother has tried 2 or 3 different hearing aids to no effect.
Okay.
They just don't help her. And it was thought that possibly she has a damaged nerve in the ear canal. Like she had fallen a couple times.
Okay.
And the possibility was that something was severed.
Okay, so the question is, this lady's mother has tried hearing aids a couple times to no success, indicated that there maybe is nerve damage in the middle ear. A little out of the scope of my counseling, what I would probably say to you, 2 things. Did she have good support around getting used to her hearing aids? Because a lot of my work is, I don't hear it often now, maybe because I've been doing this job long enough and people in the business know what I counsel and what I tell people. But sometimes clients told me, well, I've been told go home and wear your hearing aids every day, all day, and in 2 weeks you'll be fine. And I tell my client, being the older adult, throw that out with the bathwater. If your hearing changed at 51 and you're now 81, how can you get used to sounds you've not heard for 30 years in 2 weeks? You can't do it. Because the older adult also has other issues probably. So I work with people to start slowly, kind of like the tortoise and the hare. The hare took off like a flash, but the tortoise was the one that ended up winning. You go slow, you start at home. So that's how I counsel people to get used to it. If there was nerve damage, that I think you would be best to, if you're going to an audiologist, or go to your family doctor and ask for a referral to an ear, nose, and throat specialist to rule out that physical reason for the hearing aid not working. So rule out the physical, and if there's no physical reason, then call me, and I often go in and start afresh or get those little gems out of the box, figure out what the issue. We've been brought up to be very proud people. We're supposed to know everything, and it looks bad, or we think we're stupid, or we should understand this, but hearing aids are complicated little beings. There's 5 different styles, and we can refer to them with all sorts of acronyms, and you're sitting there and it's like a whole new language. So I work with people to pick the best hearing aid for them, to get used to it and to work at it. And I tell people this may take you 6 weeks, 3 months, 6 months, or a year. So you have to work at this because your hearing loss has taken a long time to develop. So give yourself that chance. And I, in my program, will come back as long as people want me to. There's no time limit. You don't get 5 visits and then there's a dollar figure. I can come back 5 times or 55 times. I come back till you say you're doing fine. And I think by the look from Julie's giving me that my time has run out. So I will thank again for being part of it, and please give me a call for those that are watching this at home. I'm just a phone call away. I'm more than happy to come and help you. Thank you.
Well, thank you very much, Mary. That was a wonderful presentation. And now here we have Dr. Cassie Reed to talk to us about vision and the risk of falls if our vision is impaired. So thank you, Cassie, for joining us.
Hi everyone. I'm going to talk about how vision relates to risk of falls today. And vision is really important because it allows us to place ourselves in our environment, whether it's a familiar one like our home or elsewhere. It allows us to spot hazardous obstacles in our path when we're walking and moving, and it contributes to our maintenance of balance, whether we're standing still or whether we're moving. Vision is something that becomes more important as we age as well, so much so that in older individuals, if a person were to close their eyes, sometimes they can even lose their balance because they lose the visual cues that allow them to maintain their postural balance. With impaired vision, that also increases the risk of falls. And when I'm talking about impaired vision, today I'll be referring to older adults. Impaired vision can happen in people of all ages, but since the consequences are more severe in our elderly population, that's who we'll be focusing on today. So there's a few changes that we can expect with our eyes as we age, and one of the ones that I hear about quite often in the office is in regards to the changes to the lenses. So the lens is behind your colored iris, and that becomes thicker over time, and it also becomes more rigid, so it affects our ability to accommodate or focus. It becomes harder to read that book, it becomes harder to focus on our cell phone, and we start moving things back and forth, tromboning, trying to see it clearly. This process is called presbyopia. It's expected, and it usually becomes noticeable in our 40s. Glare also becomes more bothersome. A common complaint I hear is in regards to nighttime driving, the glare from those headlights coming towards your eyes. Also, lighting requirements change. It becomes more important to have that good gooseneck lamp shining on your novel, or direct sunlight to see those fine details. Contrast sensitivity can decline as well, and eventually you can get a cataract developing in that lens in the eye. So, presbyopia creates a need for multifocal corrective glasses. So we now need glasses perhaps for distance vision, but we also need some help with focusing too. So there's two general kinds that we see. They're the line bifocals, that little line below the eyes. And then there are the invisible bifocals or multifocals, otherwise known as progressives. Both of them work in the same general way. They've got the distance prescription on the top of the lens so that we can see to drive or see faces, and then the bottom has that near prescription in it so that we can see the fine details up close. But this design can be a problem when we are walking, when we're looking down on the floor. What if we're looking through that near prescription? All of a sudden, we have blurry vision. We have reduction to our depth perception. It's hard to judge maybe where the lip of that step is. We have reduced contrast sensitivity. Maybe it's hard to even tell where the step begins. It's difficult. So one solution could be to get rid of that near prescription. Why not just have no glasses at all if your distance vision is good, or perhaps just have a pair of distance glasses that allows us to walk and move without that problem in the bottom of the lens? Well, that can be a bit expensive for some people. It can be a little bit cumbersome to have a second pair of glasses with you at all times. And also, who's going to remember to switch up their glasses when they're about to move? So, visual impairment is more than just blurry vision. It can include a number of different things like reduction in your visual acuity, changes to your visual field, your side vision, contrast sensitivity loss, or changes to your depth perception, or otherwise known as 3D vision or stereopsis. You know, it is possible to have 20/20 visual acuity and still have a visual impairment. 20/20 does not mean perfect vision. So visual acuity it's a measurement of how sharp or how clear our fine detail vision is. And 20/20 is considered very good, not perfect, but very good. And we can understand it probably best by doing a comparison between perhaps someone with 20/20 vision and someone with worse vision. So an example I have is perhaps someone with 2200 vision. So that usually corresponds to just barely making out that big E on the reading chart. So if I have 2200 vision, I'm standing 20 feet away from the chart, I can just barely make out that big E. Someone with 20/20 vision can walk 200 feet behind the chart and still make out that large E. They have a vast advantage in making out that detail. We use visual acuity measurements to compare vision. We also use it to meet certain standards, such as driving. So in Ontario, a regular license requires 20/50 vision in order to drive. So visual acuity is important for those fine detail tasks like threading needles, reading, seeing facial features, perhaps even reading lips. And older people that have reduced visual acuity can have problems with walking. They tend to slow down. It does increase the risk of falls. We know that if your visual acuity is reduced, the more it's reduced, the higher your risk of falls. Peripheral vision has a similar relationship. People with reduced visual fields also have reduced walking speeds, and they are more likely to bump into obstacles when they are moving. And peripheral vision changes often go unnoticed until there's moderate or advanced changes. The worst visual change for fall risk happens to be the bottom portion of your visual field. That's where you're not noticing the raised edge of carpets, you're not noticing the cats, you're not noticing several things by your feet that you could be bumping into and tripping over. Most common cause of peripheral vision change happens to be glaucoma, which is known as the silent thief, because there's typically no symptoms. Depth perception or stereopsis allows us to judge distances accurately. So a good example would be a curb. Curbs, you know, they have got a certain height. You need to be able to judge how high it is so that you can step safely onto it. And we use our two eyes together to judge those distances. So if someone has only one eye, or if they have a great difference in the visual, in the vision between the two, then they're going to have difficulties judging those depths. So I have an example of differences in contrast sensitivity. There's two sets of stairs on the screen, one to the right, one to the left. Which one would you prefer? Which one would you like to take when you're walking upstairs? The right. Why?
You can see it.
Yes, okay, so you can see the one on the right. You're right, it's very well illuminated. It's got railings on both sides, and you can see the high contrast colors that delineate where the stairs begin and end. So you've got the blue tile on the lip of the stair, and then you've got the nice orange yellow tile showing the flat part of the stairs. Whereas the ones on the left, they're in shadow. It's poor lighting in the home. It looks like they're all the same color as well. So if we, presumably without any visual difficulties, prefer the one on the right, what about those with reduced contrast sensitivity? It's another fall risk in the home. So most common eye conditions in the elderly population are cataracts, macular degeneration, glaucoma, diabetic retinopathy, which is a complication of diabetes, and uncorrected refractive error. Cataracts are the most common cause of blindness within the world. They're caused when the lens behind that colored iris becomes cloudy, and that's usually an age-related process, but it can happen in younger people as well, even in babies. Symptoms include blurry vision, the glasses don't correct, feeling like there's a film over your eyes, or perhaps even having increased glare at night with, again, those headlights. Cataracts are treated by surgical removal. So the surgery is still an invasive procedure, so there is still some risk, but it is a very common procedure these days, and it's quite successful. Typically, a person will go for cataract surgery when their symptoms become visually significant, so when your daily activities are being affected. Age-related macular degeneration is the most common cause of blindness in North America for those 65 and older. AMD affects the part of the retina that is in the center, the macula, and that affects your appreciation of fine detail. So initial symptoms could be blurry vision, distortions with letters when you're reading. Advanced AMD can result in blank portions or scotoma within the center part of your vision, while peripheral vision is unaffected. There's two forms. There's the dry form, and then there's the wet form. The dry is by far the most common, and that typically has slow changes, whereas the wet can result in very sudden changes to vision. Wet form happens because of leaking blood vessels at the back of the eye, and treatment usually involves an injection of medication to dry up those leaky blood vessels. There is currently no treatment for the dry form of AMD, but we do know that a diet that includes a very specific vitamin supplement that includes lutein can help slow down the progression of those with moderate AMD. Glaucoma is a progressive degeneration of the optic nerve, and that is a bad thing because that optic nerve takes signals from your eye to your brain. And early detection and treatment is really effective in slowing down the progression of glaucoma. The mainstay of treatment tends to be an eye drop. It's usually used at night that lowers the eye pressure. There are many forms of glaucoma. Most common ones typically are caused by high eye pressure within the eyes, but there are other ones that don't. So the drops do effectively lower pressure. Sometimes laser treatment is used to lower pressure, and surgery may be an option if required. For those who do have symptoms with glaucoma, they might have halos around lights. They could have reduced peripheral vision and problems with their contrast sensitivity. Diabetic retinopathy, that can happen because of changes to the veins and the arteries in the eyes. Those blood vessels can swell, they can form abnormally, they can leak, and that can lead to symptoms of splotchiness within the vision or drastic changes in prescription. I had one patient who really enjoyed his wife's baking over Christmas, and as a result, his prescription changed dramatically. He came in and said, "I no longer need my glasses to drive." And I said, well, let's check on that. So we did, and sure enough, his vision was amazing. He was getting 20/20 details on the chart, whereas before he needed glasses to do that. So that didn't mean that his eyes were better. It meant that his blood sugars had caused swelling within the lens within the eye. So it took us 3 months to get him back to normal, to get him back to a healthy eye, and to get that swelling out of the eye tissues. Now, uncorrected prescriptions are also a large cause of visual impairment in older adults. Up to 1/3 of older adults have issues just because they don't have glasses. They may have outdated glasses, or they have the wrong glasses. So it's a simple change to improve vision. Okay. But why don't all senior citizens get annual eye examinations? Well, some people may assume that vision becomes poor with age. And while the risk of eye conditions does increase as we get older, that doesn't mean that they come hand in hand. As we talked about, there are many treatments that we can do for eye conditions to improve vision or keep it nice and functional. So that is not necessarily true. There's also perhaps difficulties with accessing eye care due to frailty or problems with mobility, getting to your appointments, getting to the office, and perhaps even a belief that it just might be too costly to get a new pair of glasses. So there's some simple changes that you can do in your home to decrease your risk of falls, and it can be as simple as changing the lighting in the home so that you don't have those shadowy stairs, that you can, see the lip of the carpet. Also using high contrast colors to highlight tripping hazards. I went home to visit my mom this past year, and as I was walking down to the basement, I realized that someone had very nicely painted all of the stairs a lovely gray color, and had also painted the cement the same gray color. So we put landing strips on the side of the stairs in a bright red tape so that she wouldn't trip over the tape if it came up, but also, just like at the airport, it's a landing strip to bring you home safely. Okay. When glasses aren't enough, if perhaps there is some irreversible vision impairment, that's when we can use other aids to optimize vision, like low vision aids. We're talking about hand magnifiers, stand magnifiers, perhaps tints in the glasses to help with very distracting glare, also telescopes. There's also high-tech aids such as software to allow you to do enjoyable internet surfing if you want, reading bills, reading correspondence, signing checks. Those are things that really help with those with visual impairment. We also have some great resources within our community, such as the CNIB and the Center for Sight Enhancement over at the University of Waterloo. CNIB can do some orientation and mobility services within the home, and the University of Waterloo has a suite of services available to patients who suffer from low vision. So, bottom line is you can reduce your risk of falls. Don't assume that poor vision is normal. There are many treatments that we can do to improve vision or optimize vision, even if you do have an irreversible vision loss. And visit your optometrist regularly. OHIP covers those eye exams for those 65 and over and 19 and under every year. And even if you do have conditions like cataracts, diabetes, glaucoma, macular degeneration, if you're between 20 and 64, those are covered under OHIP as well. So get your eyes checked. Okay. So I'll open up the floor to any questions. Doreen, yes.
when I'm driving at night and it's raining, the glare from oncoming traffic is really intense.
Right.
Would you suggest possibly like a yellow lens to eliminate the glare?
That is a great question. So the question was, when driving at night, especially in the rain, would it be advisable to use a yellow tinted lens to cut down glare? So that's a bit of a complicated question. Any tint that you have in glasses will cut down the amount of light or information that you are getting. And it's on an individual case-by-case basis. For some people it could be a detriment, but if that yellow tint is cutting down on the distraction of glare, it could be useful for driving in those situations. But ideally we don't want any cut down of information, but sometimes glare can be just too distracting and make it quite unsafe to drive. Any other questions?
Could you address dry eyes, especially in women?
Thank you, Mary. So the question was, could I address why dry eye happens, especially in women? So dry eye is something I hear about all the time. It's very common. It tends to become a more common complaint as we get older. Women, unfortunately, go through a very significant change with their hormones in the 40s and 50s, and that can result in reduced tear production. So we're starting to hear of problems with irritation, itchiness, feeling like there's something in the eye, and those can all be signs of or symptoms of dry eye. There are a couple different kinds of dry eye. One could be based on a deficiency of water or aqueous that you're making. Another one could be based on inflammation of the eyelids. Depending on the kind of dry eye you have, the treatments vary a little bit. But it is chronic. It tends to be something that we have to address on a regular basis. And because we have such large shifts in our weather in Canada, we go from a very humid summer to a very dry winter, that can exacerbate symptoms too.
Is a follow-up question, is there any over-the-counter eye preparation, one better than the other? Anything to stay away from if you just have dry eyes?
So the question is, for over-the-counter eye drops, are there any that are better than others, any to stay away from? There are several options for artificial tears in your pharmacy, and I will typically suggest 2 or 3 different kinds made by different companies that I think are equivalent in my office. The only ones I would stay away from are products that are for red eyes. So they have an additional medicinal ingredient in them that cause the blood vessels of the eye to shrink and look white, and that effect lasts for a few hours. But if you're using an eye drop like that on a regular basis, it can cause rebound redness. So it's not solving the problem, it's masking any problem that might be there. Yes?
And do you recommend laser eye surgery for vision correction? And if you do, is there any age in which you maybe wouldn't recommend it, or is it just depending on your eye?
Okay, the question is, would I recommend laser refractive surgery? And is there a specific age that would be good or not good for that procedure? I'm not a candidate personally. We do refractive surgery consults at my office. And the most important thing to consider is a good screening examination. And all of the laser centers within our area, indeed I think within Canada, will offer complimentary screening to let you know what your odds of success are, what your risks are, go through the entire procedure with you so that you know what to expect. Is there a good age to consider for the surgery? Typically, considering it within the mid-20s is a good time to start, because at that point many people have eyes that have stopped changing. One thing to consider is that presbyopia that we were talking about earlier. If you do have refractive surgery that corrects both eyes for distance, you will still be affected by presbyopia. So in the 40s and the 50s, you may start to notice that it's harder to focus. and have to resort to glasses or multifocal contact lenses. They are working on additions to the traditional refractive surgery to help us with that focusing issue. And that's something that you can explore with the refractive centers if you're interested. Yes?
If you had the refractive surgery and you required glasses again, can you wear contacts after you've had the surgery?
So the question is, if you've had refractive surgery and you ended up having a prescription develop, would or could you wear contact lenses again afterwards? The refractive surgery typically changes the shape of your cornea. It's reshaped with that laser. It becomes usually flatter for most of us. Contact lenses can be a bit trickier to fit after refractive surgery, but it's definitely not a contraindication. So there are a few patients that I've seen who have had LASIK in the past who do still wear contacts. Yes, Dorian.
Excuse me. There's a condition called Sjogren's syndrome.
Right.
Is that basically dry eye?
Sjogren's syndrome does cause dry eye. It's aqueous deficient dry eye, and it can be quite debilitating for many people. There are, other than some of the mainstays that we use, such as artificial tears or hot compresses, some people with Sjogren's have so severe dry eye that they need to go on medication to help increase their aqueous production. It is typically related to autoimmune conditions. Yeah. Okay, thank you.
So thank you, Dr. Cassie Reed. That information was very informative. And I hope you at home found both the information on hearing and vision informative and helpful. But if you would require further information in either of those topics, both Dr. Cassie Reed from the Upper Grand Eye Care and Mary Young from the Canadian Hearing Society's information will be displayed following this session. Our greatest glory is not in never falling, but in rising every time we do. And it takes the community to prevent a fall. Thank you.
For more information about the free, smart, gentle exercise programs in your area, check out the Vaughan Smart website at www.vonsmartexercise.com or contact Smart Program Coordinator Kelly G by phone 519-323-2330, extension 4954, or by email at kelly.gee@von.ca. The preceding program was brought to you by Wightman TV and Bruce Telecom.